Hello, everyone. We'll go ahead and get started here. My apologies for those of you standing in line. I hope you can at least enjoy some of this while getting lunch. But I want to welcome you to this lunch symposium sponsored by OpSens. I want to thank OpSens for their support of this live case recording symposium that we want to share with you using the SavvyWire. So if we could have my slides up here. So I'm going to start by sharing with you an interesting case, and I think it really speaks to some of the things we're going to be seeing down the line, and it's a hot topic with regards to lifetime management of patients with aortic stenosis. So I'll start with the case, and I have my moderator, Dr. Philippe Genereux, who's also going to help lead some of the questions, and we'll go from there. And so we can go, oh, it's me. Sorry about that. Okay. Okay, so this was a 79-year-old woman, and it was interesting. She had had a TAVR done at her Nightslide Hospital, and this is done out west of us. And at that time, she had a 29 millimeter Evolut Pro Plus, and it was implanted at a 4 millimeter depth. The implant really went really well, and she did well overnight. And the next day, she started complaining of chest pain, and at that time, the physicians there then did another look, and they saw the valve had moved. And there was also a lot of AR. And they were interested into seeing what had happened. They did a repeat CT, and they said the CT had shown that the well-implanted Evolut had unfortunately migrated into the LV. And she did initially well. They tried to manage her medically, but in follow-up, her EF went from 56 down to 40. So she comes for evaluation, and this is her echocardiogram. And I think we could probably agree that the LV function is somewhat mildly depressed. I'm not an imager. I'm not going to pretend that I'm an expert at echo, but just globally, there was some reduction in the LV function here. And here we can see on the echo, on the left-hand side, a 2D image there with the Evolut prosthesis in place. And I think in the middle, I think we can all agree that there was quite a bit of AR. Here on the right-hand side is a short axis of the valve. A little bit difficult to see where the location of that AR was arising, but it was clearly felt to be paravalvular. She had a TE done, and here are some additional images, and one can see that the Evolut valve, which again was implanted well, but unfortunately had migrated a little bit down south. Do you mind dimming the lights just a little bit facing me? That'd be great. And then in the middle image there, one can see that there was a lot of AR, and again, that short axis on the TE showing that essentially the AR was all PVL. She had a cardiac CT done. This is done obviously after the Evolut had gone in, and one can see here the positioning. One can also see the origin of the left coronary artery there, and it's actually a little bit hard for me to see the numbers there, but in the frame, the circumference was measured at 70. So I want to ask Janarthanan, Vinny, and Philippe, initial impressions on this placement and where the valve ended up, and the sizing. You want to turn yours on?
Yeah. Okay. Yeah. So obviously, no surprise. The valve is low, so I think probably PVL are above the skirt. So that's probably the mechanism. So first thing I think is the waist of the core valve looks like a 23 valve sapien could be fit in when you look at the area 375. The question is, can you plug the leak? Can you put a valve to stop the leak because it's above the skirt of the Evolut? So my inclination would potentially to put a sapien 323 where it is 23 actually eye implant. The question is why it slipped at the beginning with? Was it on undersized?
Yeah. Under or oversized?
Yeah, probably oversized. Yes.
Oversized.
Yeah,
Oversized relative
yeah,
to the
probably
native.
oversized and it slipped forward.
Yeah.
Yeah.
Vinny, what do you think about the sizing?
I mean, this is definitely oversized. This is not uncommon, right? If we are too oversized, it's most likely it migrates down, or we are trying to place it right, it pops up. So I think it must have been a real big oversize, especially looking at the area of expansion now. So I think it's probably oversized.
Janar?
Yeah, I mean, I think the points have been raised nicely by Philippe and Vinny. One question I think is taking a step back is the mechanism, right? So was this valve severely calcified initially? Was it an AI issue? So I think understanding those mechanisms would be nice. It would be good to also see the original CT measurements that were done. And it may be that, no different than if you were to have a sapien, you're in between two sizes. We've had cases of embolization picking the smaller valve and a valve that was not very calcified. So I think understanding the why will help you, as I'm sure you'll show with how to fix this.
So it was stenotic. I don't have the calcium score, but I believe it was a calcified valve. And to Vinny's point here, we're measuring at the annular level. So if it's a perimeter of 70, this 29 was probably a little big, at least based on our measurements. And the tracing we're doing there is at the frame, right, Vinny? It's through the frame, which is probably how we should do these, but it might have been even smaller than 70 if you look at this perimeter. So, we look at this. So you've got a 79-year-old. It's a 29 evolute. It was placed 8 months ago. She had been hospitalized for heart failure. She's got severe PVL. Her EF is 40. She's doing okay. She's actually ambulatory as an outpatient. Next steps, Philippe already offered sapien and evolute. Vinny, what would you think about the surgical explant for this? I mean, how would you think about risk, technique?
I think you can, this is one of the patients where you can treat with TAVR and TAVR for sure. The main problem with these patients is the injury to the anterior mitral leaflet as we go ahead, because the evolute is very low, and the mitral leaflet, whether we like it or not, is going to hit that permanently. But I think this patient has recently had a TAVR. It's fair enough to consider TAV and TAV if there is no excessive risk in terms of achieving good hemodynamics or coronary obstruction. I think we'll still have to keep a watch on her in terms of her mitral valve, and anterior mitral leaflet perforation is not uncommon.
So to go back to the TE here. There you go. So it is a little bit low. The anterior leaflet looks like it's butting up on there. Sheesh, what do you think?
The concern about the anterior mitral leaflet that Vinny raised is legit, but I think the point I was going to make was related to the fact that at their 1 month follow-up echo, did they not appreciate that there was severe PVL? Because I don't see LV dilation and I don't see long-standing AI. So to answer that original question, I think the index implant probably was for AS with maybe fibrotic, or you don't have enough calcium on the leaflet for whatever reason, but the sliding down probably was related to, as Vinny said, oversizing, and the acute hemodynamic impact probably happened immediately at the time of implant, but was not recognized at the 30-day follow-up. And the treatment, I think I agree with what Philippe says. I think preferably put in a S3, and I don't think there's risk of coronary obstruction or creating a scaffold like you would if you put in a self-expanding inside this.
So he's saying sapien, not another evolute. Janar, you're world's expert on valve and valve.
I don't know about world expert, but certainly spent a lot of time playing on the bench. But I mean, I think to Vinny's point, if you look at a lot of the cases that have been done or presented at meetings with sapien and evolute, the risk of obstruction is quite low, and partly if we look at historical implant depth and technique, the valve ended up much deeper than what we implant now with evolute, with the cusp overlap technique. So as it relates to this case, this valve is essentially an intra-annular position with its leaflets. So the risk of obstruction is going to be almost nothing, I would suspect. There is one other concern beyond the mitral leaflet that I think somebody presented a nice case a few years ago at TCT where there was a low deployment and actually the patient, not that this patient has that, but they had intractable runs of VT because of the frame interaction related to a deep implant. So
Was that a papillary muscle interaction?
they believe so. They weren't really sure. The patient, I think, in that case, went for an explant in the end, but they kept having runs of VT with that. So there, there's other consequences to a deep implant as well.
What would you say about the lifetime management? What do you, Philippe, all three of you, what would you say in terms of, this is a 79-year-old woman.
Yeah.
And what is is there a lifetime risk of TAVR and TAVR different?
So, I think we have to be, as we talk about serial procedures, and this was one thing that came up with Uri Landers' series, is that I think we have to be very clear on the distinction about a repeat procedure for a first valve that had a suboptimal result versus a valve that has degenerated and failed. So this case is really you're trying to address an issue with a suboptimal implantation. So when I think lifetime, I'm thinking more about a valve that is degenerated over time. Just as an aside, if say this patient had come and essentially they have a small annulus, right? So the one thing that comes up with regards to that is, of course, hemodynamics, but when you're balancing different types of platforms, it's also important to think about repeatability because the smaller annuli is the exact situation where you have a potential risk of coronary obstruction or sinus sequestration, depending on the platform that you choose. I don't know, Philippe and Vinny?
Yes, I think this case is very particular, is very specific because you have an early failure. It's not like it's a long time failure. At 79, I think or 77, the choice of TAVR was appropriate because it didn't seem to have a lot of adverse feature for TAVR. Now you have a leak. The question is, can you fix this problem without compromising early or midterm prognosis, which I think you could fix it easily. But if other feature were there, if there was a mitral stenosis or other stuff like that, I think it's become a surgical case. For her, if you put a balloon expandable valve, which I would favor here because of the amount of metal, are you gonna put a little 3 months of NOAC and then go to baby aspirin? But I think for me, it's because it's an acute failure that is easy to fix. I think I would favor TAVR in TAV. Yeah.
One more question and we'll move on. But Vinny, is it easier to remove an evolute now, 8 months after her previous implant, or in 10 years with the sapien inside it when she's 90?
So I think that's a great question. And, so here we are managing patient expectations as well, to be honest. Ideally, this patient should have an explant now. We decided as a heart team, we means whichever team, and they decided, okay, TAV was a great option for 79. It hasn't worked well for whatever reason. I think trying to fix this with another TAVR device is reasonable from patient's point of view. And I think we should not lose sight of that as well. But at the same time, going ahead, explanting this valve with 2 devices, 1 balloon and 1 nitinol, is again going to pose a much bigger problem. So I think I would say that from patient's point of view, she had a TAVR for optimal results. So we can still probably put a 23S3, which she would have had anyway before. And as I said, if she has good hemodynamics with it, it's reasonable.
Okay. All right. So when we're talking about this, I think, there are a lot of considerations technically in terms of TAVR and TAVR. We think about the sizing. What was the size? What was the native size? What is the now new size with the TAVR in place? What is the coronary risk? We think about, Philippe mentioned that likely this PVL is because the skirt's too low and the leak is coming over, and that's what we think because it's kind of deep in the LV. And we think about the frame heights and the implant depths, and honestly, when you put all this together, it's many different parts to a matrix. And to have, these different diameters and perimeters and skirts, it actually becomes quite complex. So I want to invite our scholar in the Valve Science Center, Miho Fuke, who has been helping to pioneer these TAVR and TAVR analysis, and she's going to describe what she did for analyzing the patient planning for this procedure and determining what feasibility there is. Miho? Yeah.
So before I'm going to show you how we perform the city planning for this case, I'm going to present what's a strategy, how to plan by city step by step. So for the first step of pre-procedure city planning of tau in tau, we need to understand the structure of an index tau with device-specific landmark. It's not for evolute. So node 0 is the inflow level, and node 3 is the level of the inner skirt height. And leaflets start at node 3 and ends at node 6. So node 3, 4, 5, 6 are important landmark for evolute. Second step is select second tab. At present, we have 2 second tab options for evolute in the US, Sapiens 3 Ultra or evolute FX. Once you define the index tab and second tab, a neo-scut plane will automatically be determined. What's a neo-scut plane? So to treat failed evolute leaflet with Sapien, we need to put Sapiens 3 at least at node 4 and maximally node 6. If you implant at node 3, it wouldn't be treatment. It would not pin the leaflet at all. If you implant higher than node 6, there will not be hemodynamic benefit and increase the risk of migration. So when Sapiens 3 is implanted at node 4, the neo-scut, which is a portion of the tab-in-tab combination covered by the inner skirt and or leaflet, will reach at the node 4. So the neo-scut plane is node 4. When Sapien is implanted at node 6, like this, the neo-scut plane will reach at node 6. So the neo-scut plane is node 6. For evolute in evolute, it's simpler. We have no choice. Just implant same as the index tab, index evolute. So leaflet of the index evolute pin all out. So neo-scut plane is node 6. So neo-scut plane is determined by the combination of the index and second tab. So importantly, the neo-scut plane is independently from the native patient anatomy and also the implant depth of index tab. The neo-scut plane is also determines the risks of coronary and leaflet overhang. For Sapien in evolute, generally lower implantation has lower risks to coronaries, but greater degree of leaflet overhang. The higher implantation has higher risk to coronaries, but less leaflet overhang. Evolute in evolute has higher risk to coronaries, but no leaflet overhang. So the ideal tab-in-tab implantation is no risk to coronaries and no leaflet overhang. If it's impossible to achieve that, second choice is a no risk to coronaries and some leaflet overhang, but acceptable hemodynamics. So the ideal tab-in-tab implantation for a patient is defined by the relationship between the neo-scut plane, which is determined by the index and the second tab combination, and coronary risk plane, which is patient-specific. So next step is identify the coronary risk plane, which is defined as the level below the lowest coronary ostia. How to identify that? So first, identify the bottom of RCA ostium with respect to the node of evolute. Do the same thing for the LCA, and you can identify the coronary risk plane as the lowest node. And assess the relationship between the coronary risk plane and neo-scut plane, which will determine the implant position where we should implant. So when the coronary risk plane is at or above node 6, we can implant sapiensly at node 6. And as you can see here, both coronary is above the neoscot plane, so no risk to coronaries and no leaflet overhang. This is our ideal implant position, but it's rare because it's only happen deep implantation. And the second scenario is a coronary risk plane is between node 4 and 6. So in this case, we can implant the sapiensly at the same level of the coronary risk plane. Still no risk to coronaries, but some leaflet overhang, but acceptable hemodynamics. The third scenario is the coronary risk plane is below the node 4. So remember that we need sapiensly at least node 4 if you want to node 5 or 6. But as you can see here, the neoscot plane is above one or both coronaries. So we will need to assess risk to coronaries by measuring the VTA. And there are some leaflet overhang too. So once you decide the implant position, which means a neoscot plane, we can move to the sizing. This is because sizing zone depends on the implant position. So once you decide where implant, for example, node 6, you measure the area at node 6 and 3 nodes below, so node 6, 5, 4, 3, and use the average area. And if you decide implant at node 4, you measure the area at node 4, 3, 2, 1, and use the average area to choose the size. So this is the essential strategy for Evolute. So based on that, I'm going to show you how exactly we perform CT-based planning for this case. First, this picture shows what happened in this patient. So due to the migration, the level at the native annulus corresponding to the node 4, which means the node 3 in a scat level is below the native annulus. So through the between node 3 and 4, regurgitation came through. So now we know that step 1, index term, this case is a Evolute Pro Plus 29. Step 2, choose the second term. We choose the sapiensly because lower risk to coronary. And third, determine the neoscot plane. So for sapien in Evolute, we know that nodes 4 and 6 is the neoscot plane. So step 4, identify the coronary risk plane. I hope oh, sorry. How can I move back? So can I play the movie? Thank you so much. So first, identify the bottom of RCA ostium. So first I just adjust the line to get the perpendicular line to the Evolute. A little bit adjustment. And then identify the RCA. And then moving down the plane to the bottom of RCA. And identify the location with respect to the node of Evolute and count from the inflow 0, 1, 2, 3, and then this case has a node 7. Do the same thing for LCA. Identify the LCA and moving down the plane to the bottom of LCA and identify the node of Evolute from the inflow, counting 0, 1, 2, 3, 4, 5, 6, and the house. So this patient has a coronary risk plane at node 6.5. So next, step 5, assess the relationship of the coronary risk plane and the neoscot plane. This patient has a coronary risk plane above the highest neoscot plane, which is a node 4. So in this scenario, we can implant the SAPIEN 3 at node 6. And again, as you can see here, both coronary are above the neoscot plane, so no risk of coronary risk obstruction, and also no leaflet overhang. So for this case, we don't need to risk assessment. So move to the sizing. So we decided we implant at the node 6. So measure the area at node 6, 5, 4, and 3. And calculate the average. Based on that, we choose a 23 SAPIEN 3. So this is one size smaller than the in vitro recommendation. So we made sure this size is appropriate for this patient at the level of native annulus, withdrawing the virtual circle of 23. And as you can see here, like left side, no undersizing and no excessive oversizing. On the other hand, so we also made sure with the 26, which is the in vitro recommendation size, if we use this size, it could be the excessive oversizing and could cause a risk of annulus injury. So we decided to stick with 23 S3. And this case is a PBL, so we also made sure this implant position will cover the between node 3 and 4. So we made sure that. So this is a final summary report. So this case is a Evolut 29. We will recommend the use of SAPIEN 323. And implant level is a node 6, which means 8 millimeter above Evolut inflow, which corresponds to the between node 1 and 2. And in this case, no risk to coronaries and no leaflet overhang. So that's it.
Excellent. So, so Miho says we can do it, and Vinny says he'll fix it if we mess it up. So, so we decided to go ahead. So,
Paul, can I just make one quick comment?
yes,
Just
Janarthanan,
because I
please,
think,
go ahead.
you know, I think we have to pause and just highlight how crucial that part of it, because that to me is the most important part of the entire case.
Yes.
Just rigorous, systematic assessment, and it was such an elegant demonstration of how understanding the depth of the first valve, how that has an impact on risk. But the second most crucial thing is not really trying to sort of partly ignore the valve size that was implanted. Because if you just thought quickly in your head, it's a 29 evolute, that's typically what I put a 26 in, that would take you down a potentially dangerous route. So that careful assessment of the valve size, and if you have obviously the pre-implant CT as well, is just so important for this. So I think that was really just beautifully done.
Excellent. I completely agree. So this is how we did it, and I want to share this with you. It was a really straightforward procedure plan. We did bilateral femoral access, and you know, usually with these valves, you can actually just do single access and use the SavvyWire, and I want to talk a little bit about that. The reason why I had two accesses is because this valve had been put in just 8 months before, and it had already migrated into the LV, and I wanted to snare and just hold it. I just wanted to be absolutely sure, because this was a young woman, and I didn't want to make things worse. And so I used one side to gooseneck snare the evolute, and then I planned for 23 SAPIEN, as Miho very elegantly described. So just a few things about the SavvyWire, and again, I want to thank Opsens for sponsoring this symposium. This is a nice wire that has both pacing and pressure capability. It's an 035. It comes in a 280 centimeter length. There are two sizes, extra small and small. It's got this insulated sleeve. It does require you to ground the patient, but it's a really nice wire that allows things to move relatively quickly because of that hemodynamic sensor as well as pacing. So it saves you the pacer access and also can expedite how quickly you can assess your acute result. And so I'll show that for you, to you during the procedure. We also use the EGNESS medical system, and this is a nice system that helps prevent radiation scatter over 90%. This is our setup in the lab with this to protect everyone as well. And so I want to go to the live case recording, and in the interest of time, I'm just going to go, could we go to, and I think you have to fast forward it to me, to 2:45 in the recording? No sound, please. There's no need for sound. Yeah. But if you go to 2:45, yeah. And Caitlin and Marcus are here with me in the audience. They did this case with me. You can see, and Vinny's there as well. But if you fast forward it to 2:45 in the timer and just play from there. Yeah, that's good. So you see, yeah, if you just let that play, okay, and then we do an aortogram, and you can see this is just confirming the position of the evolute. Here's the aortogram. Eventually, oh, Marcus, looks like you need to reload. There it is. So we had agreed, and this is to confirm that, you know, Vinny and I were there, we're discussing that we agreed that node 6 for the top of the outflow was where we wanted to target it, and we just confirmed, and we counted probably at least 6 times to make sure that node 6 was still at the level of the coronaries and that it was safe to do. If we could go to 4:30 on the timer, please. This just shows a setup here. So typically the way I've been grounding these, you can use a suture needle if you want, but typically I just get a little lidocaine in the sub-Q and then just a micropuncture needle. And you can see I just inserted above that pigtail sheet there and then hook up the pacer to that. If we can go to 9:07, please. So this is just a, was it a 15 or 20, Marcus? I can't remember. 20. It's a 20 gooseneck snare, and this pass through a JR. You could let that just play for a little bit. And I'm snaring, and of course the surgeon gets really smart and says to me, why don't you go REO? So then I went REO, and then of course it snared right away. And then again, I don't know if this is complete and necessary, but I just did it because I just wanted to hold on to the valve in case. And you'll see here, eventually it goes REO. Yeah, maybe fast forward a little bit there. There you go. Oh, that was it. Right there. Yep, so that was it. So we just held that in place. And then you can see the lower left-hand side there, Marcus's hands is putting a hemostat on that wire and holding that snare in place. So that just holds on to the evolute, just in case we have any problems. If we go to 11:10 as well. Right there. So this is the SavvyWire introduction that I'm going to show you. This has a Y connector. We flush as we go in. You can see the wire, which is this loop configuration, is passed through a pigtail, which has already been placed into the LV. And then there's a sensor in the back where the cable it connects just plugs into a transducer. You'll see here, it's pretty straightforward how it goes in. And then this gives us our temporary pacing wire. As we're watching this, Philippe, Janarthanan, experience with these temporary wires instead of temporary pacers?
Yeah, so we switched completely. This is our default wire. We use the SavvyWire for all our case right now. And yes, we do the same. I do a little micropuncture ground on the side. I really put away from the pigtail because sometimes if you pull, you jerk the pigtail out and you may, on ground. So be careful to that. Don't put it like next to the pigtail. You don't want to hit yourself, poke yourself, but also don't remove the grounding. And I really like the characteristic of the wire. Is very stiff in the ascending aorta, very good for horizontal aorta. And the pacing is great. Typically the threshold is at 2, but we crank it up at 20 anyway. So very good characteristic of the wire. And the V2 is very soft. So we love it. So, yeah.
Janarthanan?
Yeah, so Paul, we've used it, clinically. We don't use it for every case, but we've used it clinically, but also as part of a trial within complete TAVR to compare against invasive hemodynamics. I think it's a nice device because it speaks to the broader topic of how we're going to pace for TAVR. There's a lot of interest now in procedural efficiency. Obviously, you can kind of do a MacGyver type setup with just a cable and thing, but this is one of a few purpose-built devices that have the ability to pace. But the nice thing is also has a hemodynamic element to it as well, which I think as we expand the field to younger patients, we're going to be really more interested in that acutely and also maybe optimizing deployment. It's a wire that behaves quite nicely. And overall, I just think as you'll feel that it's very similar to a Safari, and for people that start to get to use it, it's very easy to manage. Maybe a little bit more tension sometimes when advancing the valve system, but it's incredibly user-friendly.
If we can go to 1959, I'm going to speed up ahead here. That's great, thank you. So here the valve is being positioned here, and I thought we agreed that was a pretty good spot, and we're watching the top of the inflow. Top of the inflow or the marker? You guys want to describe that for some people who may not be familiar?
So basically with these, I think it's just really you're looking at for me, I look at where the outflow of the sapien is going to be.
Top of the outflow.
Yeah.
Sorry, I meant top of the outflow or the marker.
Yeah, because I mean, I think that's the point that's going to be very, very stable. I think if you just see this, if you pause this is to me such a valuable view because obviously CT is so crucial, but we deploy in this view, right? Mm-hmm. So going to some kind of LAO-cranial from PCI work, you know that that's going to isolate the left main. And most of the time, the right originates above. So if you're deploying in this view, you know, not an issue for this case, but if you align the top of the valve below that left main, if there's a concern that's borderline, then you're going to be safe. Yeah. A question for you, Paul, how fast are you going to deploy this valve, and what's the pacing strategy? You obviously have a purpose-built wire for this, but...
We just paced at 180, and we just took our time and just went really slow. It's a very slow deployment. If you go to 23 on the timer, you'll see the deployment here. And what I really like during this deployment, so if you just look on the left-hand side, look at the upper left here, and you get real-time hemodynamics. So there's a SavvyWire, which is the yellow, and then red is the JR catheter, or it could be the side arm of your sheath, whatever you want to hook it up to there. This blue is from the SavvyWire input from the hemodynamic sensor. And if you watch this deployment and also watch these hemodynamics, it's really quite nice because you get both at the same time. Do you mind is that playing? Yeah, it is playing. And if you go to 23 on that, yep, there you go. So here comes the deployment. And you know that the snare held that evolute, but honestly that evolute didn't move at all. So you can see the rapid pacing there, super slow deployment. And then if you just watch the hemodynamics above when the pacing comes off, this I think is really, in terms of the procedure efficiency, if there was a gradient already present, you could just go right back up with the same balloon. You could add a CC if you wanted to, but right away. And so here, after the deployment, you'll see in the top left, that AR diastolic equalization, it's essentially gone. And so we're just taking this out here, and I'll show you. But you could pause here, and you could use the SavvyWire to look at the hemodynamics, and you can see in the top left, there's no gradient, and the AR is gone, even without looking at the echo.
So Paul, can you educate us on how, obviously you've got a lot of experience with this, how you use this to assess AI,
Well, I guess what I'm looking at is the AR index, and I'm looking at that separation and diastole, and here this is a really big separation, and you could calculate that AR index if you wanted to, but the other part about it is looking at the fact that the LV-EDP is normal, and it's virtually impossible to have significant AR if the LV-EDP is normal, and so that plus a large diastolic separation. Philippe, you want to comment?
Yeah, 2 points. So very good deployment. So very important to go slow, but also what we've been doing for AI case off-label or when there is risk of embolization, we like to pace down slowly, to march down 180, 60, 40, let's go over 5 seconds to avoid this big burst of.
Sure.
So we do that. I don't know if it changed anything, but it's reassuring us at least. Yeah, so AR index is available with the SavvyWire on the console in Canada, but it's going to be available soon in US also. So I think that's all this integration index for AI will be available soon, which I think will be valuable for such case.
I mean, you had a very stable deployment. I don't know, maybe I don't know if you had to move anything or, I mean, you also showed very nicely that just like doing a valve in a failed surgical valve, you don't need to inject dye for these. You know, my own personal practice, as I just alluded to earlier, I like to have a pigtail just to inject to see the left main and the outflow for borderline. This case not needed, but I mean, just very elegant deployment, and I think really succeeded by the case planning that came before.
The case planning was 99% of it. And so this was actually very straightforward. We've actually dragged it out for you a little bit. So, but just a couple of things, you know, you can use this for single access if you wanted to equalize to the femoral or some other central access point for the pressure. You know, for this TAVR, that's certainly a possibility. You can also pull the pressure sensor up into the aorta and push it back down to get LV and aorta and look at the gradients that way too. You know, and these are some of the hemodynamics, and this is the AR index that's been published before. And so anything less than 25, it's calculated according to this formula is helpful. So, so I just want to stop there and just kind of show here there's no AR. We actually did an aortogram as well, and there was no AR. So, but Vinny, do you want to close here? And we're going to talk a little bit more, all these things that Miho put together for you. She's been working with Vinny and Sushi, one of our other scholars as well, on this app. And as you know, Vinny is the originator of the Valve-in-Valve app, which has just been an incredible innovation in our field. And soon to come is the TAVR portion. So Vinny, do you want to talk about that?
So thank you, Paul. I was just saying to Jana that thank God I lost my hair before I started working on this app. This is a very complicated subject. But I think I must thank Janar for a lot of bench work he has done. And of course, my team who has experience in tolerating my irritability throughout this. So most important, I think this is my favorite quote by Dr. Ionescu Shelley, who designed the first biological valve, is when there's an incense chamber, smoke and perfume are inseparable. So whether we like it or not, every biological valve is going to degenerate. And you know, we are going to see this. Now, initially we didn't see this because a lot of these patients were already probably dead. But those who are coming back haven't posed many challenges either. Because most of these places, you know, we implanted deeper. So coronary obstruction, sinus sequestration was never a problem at all. Like here, Sapien 29, you can see that this XT is way below everything. There is no issue whatsoever. But we are implanting higher and higher, and I think we have to rethink this strategy as well, and maybe it has to be patient-tailored as we get mature in this field. But there are some similarities with TAV and SAV, but there are a lot of dissimilarities as well. For example, TAVR valves are never fully expanded like in the bench, so dimensions are going to be different. There is no defined neoskirt because you know all the leaflet designs are different. Leaflet overhang is very variable. But the depth of implant is different. So our neo-annulus, which we define for SAVR valves, are going to be variable as well. So if you look at all this, it suddenly becomes extremely daunting. And if I read these articles again and again, and this is a slide from our past fellow, Muhammad, who said it's going to be a very art, and it's an art, but it's going to be a complex art. But what we really want to do is change it into logic. Because we can look at this, we can analyze a lot of CT scans, we can take 100 measurements, but if we don't know how to use them, it's actually futile. So the whole idea of the app is, and this discussion today, is how to make this logical. And the only way we can make this logical is if we understand valve designs. If we don't understand valve designs, we cannot understand the interpretation, which is going to affect the TAV in TAV field. So a lot of effort, look at these designs, multiple designs are going to come back to us, and hence we need to understand the index TAVR design, and we also need to understand the second TAVR we can choose, make it combination specific, and then start analyzing on the CT scan what we really need. Of course, a lot of these things have been used in the past, you know, neoskirt, But I think critically it all hangs around this because we don't want coronary obstruction. Coronary obstruction is bad, and I think accessing coronaries after 2 stents inside is going to be very difficult. So the whole thing is going to play around these 2 important issues, and of course sizing is an additional issue itself. So the biggest element in the room, and we have to thank Janarthanan for that, is leaflet overhang. And I think his bench work has demonstrated that at different depths or heights of implant, the leaflet overhang, which is specifically important for tall valves, is going to be critical. But we have to think it slightly differently. And Mio showed node 4 and node 6. So if you are at node 4, you're going to get some leaflet overhang. But if that leaflet overhang is not hemodynamically significant, it should be a good compromise. And I think that is the whole idea. Initially, we were implanting it higher in every possible patient, and then people have had deaths on the table because the coronary completely gets obstructed. So I think we are going to see more work on this. We are working with Medtronic on this particular GOA of A versus L. This is again neoskirt plane, which is in the bench. So if I implant a sapien exactly 4 millimeters below, this is going to be neoskirt plane. And you can see that depending upon valve design, the leaflet overhang changes. At the same time, I can implant it for 0 leaflet overhang, but then the coronary risk can go up. So again, what I'm trying to highlight is we have to take this into consideration with the patient's anatomy. Bringing back to our case, it was a node 6 implant, which is a high implant, but because the valve was implanted lower or deeper to start with, it didn't cause us any problem. So again, very critical that we look at our first choice, no leaflet overhang, but has to be no coronary risk. If there is a risk of coronary, we should lower the plane if possible so that we have an acceptable compromise for this patient. So this is just a demonstration. This is a normal height implant for a evolutar. If I implant it at 6, you can see it's going to be above coronary. But if it's a deeper implant, as in our case, you can still implant at node 6, like on the left side, but there's going to be no risk to the coronaries. And this is why the relationship between the coronary risk plane for a given patient and a neoskirt plane, because of the 2 TAVR combination, is going to be critical. So we are going to see all these things in stepwise in the app as well, but I think it's just important to understand, again, it's a combination-specific analysis. If you do choose a sapien here versus a evolutar, your analysis is going to change, because that's, again, very important. So I'm just going to walk you very quickly in the next 7 minutes. I've taken just 2 different examples, Neo and Sapien. You can see here, initially what we do is we do some index valve specific measurements. Each valve will have separate measurements because these are the measurements which are going to influence your second valve sizing. Again, very important, these are going to be valve specific. And this has been a product of a lot of discussion with R&Ds and of course guidance from Janarthanan, Yuri, and few other friends. So for example, for Neo, we are going to use 2 measurements, node 1 and bottom of the upper crown, but for Sapien, we are going to use 3 measurements. For evolutar, remember we use 4 measurements. And these are very important because we're going to choose the second valve now. And usually speaking, for tall valves, we prefer a short valve because we don't want that neoskirt plane by default going really high, which makes sense. So this is just a table in order of preference probably. So here we have chosen Sapien in the tall valve and we have chosen Evolute in the short valve. And this is just to demonstrate. You could still use a Sapien in Sapien. So the planes here are upper crown and the bottom of the neoskirt, the commissure, and this gives you adequate leaflet coverage. And these are the 2 planes you're going to toggle between to choose which plane gives you the least coronary risk. And this is really important. For Sapien, to be honest, it doesn't matter, and I'm going to show you why. So here, I can implant it at the top of the upper crown or at the bottom of the commissure, and this will give me good fixation, good function, and now all I have to do is check which is below the coronaries. For Sapien, interestingly, whatever you implant, the neoskirt plane is only going to be 1. So here, the aim is not to increase this neoskirt plane. So remember, core valve or evolutar has inner skirt up to node 3. So I just want to match this at node 3 at the top. If I implant it higher, my neoskirt is going to increase. And it's actually no hemodynamic advantage because the leaflets start at node 3. So all we have to do if we choose this combination is implant it at node 3. So coming back again for these two, here this is my target. Right and left side is slightly different. And I'm going to now analyze the coronary risk plane, which is very simple, bottom of the lowest coronary. And you can see here for accurate neo, if I choose the lower level, it's actually better because good hemodynamics, no coronary risk. I don't need to implant it higher unless it's really necessary. While for SAPIEN, here one coronary is below. So that means I need to do coronary assessment. And this is exactly what the app is going to give you multiple choices and guide you through. So here, I don't want a higher implant, I'm going to do a lower implant. While here, to be honest, there is no choice. If I use a deeper implant, my neoskirt is still the same. So it's not going to give me any benefit by implanting deeper. In fact, it's going to make it worse hemodynamically. So I'm going to implant it with node 3 at the top. And now I'm going to do sizing because sizing affects the VTA or VTC or VTSTJ. And we have learned that from the bench studies as well as in vivo now that it really affects what size we use, affects the VTC or VTA. So this is the way we have sized, if you remember, as a starting step. So once we enter those, we are going to get average area. We are going to use the tables at present, at least till the science develops and becomes mature. And then we are going to choose the second size. So on left side, we don't need coronary assessment. We just need the size. We are going to go ahead and tell the operator, you can do this implant, but please implant it here, as we did it in our case. While on the right side, we need the assessment. And this assessment is very important. And our experience has been with surgical valves, and we say VTC is 4 or more is great. But now the TAVR stent also goes higher up. So we need to also measure higher up. So what is important is the narrowest measurement. It's not just VTC. We had a case recently where VTC was 4, but as we took it up, our VTSTJ was 0 for the right. So that means we shouldn't be proceeding without care or shouldn't be doing it at all. So I think what is critical is to do all these measurements. And then, usually speaking, if you use a balloon expandable valve, logical, right? The dimensions are going to increase. While if you use a self-expandable valve as a second valve, the dimensions are not going to increase unless you do a BAV before or after. So very important to measure, these distances. And currently, we are recommending this based on, Toby Rogers and others' experience, that if it's more than 4, the narrowest measurement, this is not VTC, this is the narrowest measurement, then there's minimal risk. If it's between 2 to 4, you can, take some precautions or send for surgery probably, or do a basilica, etc. if it's applicable. And if it's VTA less than 2, then please take all the precautions possible and do the case. So again, the app is going to guide you properly in terms of this. But critically, what we learned was, we are going to do all this on the CT workstation, but after 3 weeks, I'm going to do the case. So how do I take this and then transfer it in our operation room or, intervention lab? So what we're going to provide is 3 screens where you can take a screenshot, and this animation is going to, you can adjust the levels, and you can actually create this, take a screenshot, and import it in 3 months your report, so that when you're actually doing the procedure 3 weeks later, 1 month later, just reading the CT report is not going to help you, but an animation like this, as in our case you saw, is going to tell you if it's green on both sides, that means you don't have a coronary risk. It's going to tell you where you should implant because you're the one who has made this report. So I think this is the way this app is going to work, and we hopefully release it at TCT. So a lot of work going on, and thanks to my team, especially Mia and Atsushi and Joao, to give me a lot of input. So again, conclusion, it's specific. More important is coronary obstruction, then is the leaflet overhang. And again, we are going to learn a lot about sizing as we go ahead. And of course, the app will be free, so you don't have to worry. Thank you.
Thank you, Vinny. Just a tremendous amount of work. It's really amazing to see. We're running late, and we have another session starting in about 3 minutes. So I'm going to call it in here, but I first want to thank Opsens for supporting the symposium. It's been incredibly educational and valuable, I think, to everyone here. Please take a short break and come right back because we're going to kick off mitral this afternoon. So thank you all for coming.